Welcome, welcome, welcome to Health Issues. I'm your host, Chris Sylvain, and I'm thoroughly excited about today's show. We have an awesome guest, believe me, and I'll just tell you exactly who he is. We have the Dean of the Medical School at LSU, the Health Sciences Center, right here in New Orleans, Dr. Steve Nelson. Welcome, sir.
Oh, thank you very much. Thank you for inviting me.
Well, obviously excited to have you. First, let's just tell us a bit about yourself and your career, and how'd you get to this particular position?
Sure. So I was born in New York City. Went to New York City public schools.
New York.
New York. And then I attended the State University of New York in Stony Brook, where I graduated with honors in biology. I then went to medical school at McGill University, which is in Montreal, Canada, which is actually the second oldest medical school in North America.
Really?
And then from McGill University, I graduated as a university scholar. I went to Johns Hopkins, and then I did my training in internal medicine, pulmonary medicine, critical care medicine, and environmental health sciences at Johns Hopkins. And I took my first job, bought my first house, got married at the same time, and came to Louisiana in 1984. Actually, July will be my 30th anniversary of coming to New Orleans.
Amazing.
And I came as an assistant professor, rose up through the ranks, and I became dean of the medical school 7 years ago. My basic training as a physician is a pulmonary lung critical care physician.
When I look at the career, I find it amazing. The first thing I see is a culture shock of going from New York to New Orleans.
Well, I have to admit that when I was in New York, I never thought I'd wind up in New Orleans, but that was more to not being familiar with New Orleans.
Okay.
I can remember, as I told you, I got married July 14th, 1984, and my wife, of 3 days, we had our car loaded up with our wedding presents, and we were driving down here. My wife, Julie, turned to me and said, "So, Steve, how long do you think you're going to be in New Orleans?" And I said, "Probably 5 or 6 years. It's my first job, and that's the usual way for an academic physician, somebody who teaches in a medical school." But New Orleans has embraced my family. They've given me great opportunities, and we've been here now 30 years, and all my children are born and raised here and attend schools here, so we've been very fortunate. And actually, New Orleans is a very cosmopolitan city with a lot of special flavors, which makes it unique, but it's not all that dissimilar from New York. It's a very rich environment, cultural environment, very much like New York, just on a smaller scale.
I've heard that before, and it's amazing just to look at it within that context. And then also as a physician, we always speak about the brain drain where those have to leave New Orleans, but then again, to see the impact of people.
So there's something very unique about Louisiana. So I've been here 30 years, but I've been in other places. There's a tremendous amount of commitment to Louisiana and to New Orleans, particularly from the citizens of this state. And so I have students that attend my medical school that could go to Hopkins or Stanford or Harvard or any place they want to go. But they decide to stay here because they're committed to New Orleans. And especially since Katrina, in terms of rebuilding the city and doing things maybe a little bit differently, perhaps a little bit better than we did before, there's a tremendous commitment of the population here. I also, those students who elect to go away to do part of their training at, Stanford or another university, we welcome them back, and they're anxious to come back. So it's very easy for me to recruit a physician back if one of the partners was born in New Orleans. So if there's a spouse that came from New Orleans, half of my recruitment discussion is over, which is very good for me. Again, it's a rich environment, a great city, and people have a great passion for this city, which I share as well.
Hey, that's awesome. That's awesome. Well, let's talk about the concept of a doctor. A physician. It's changed over the years. Give me some concept background to that.
So, as I was trained, it was pretty much conventional, education for physicians at that time. The first 2 years, you're taking your basic sciences, physiology, biochemistry, anatomy, and as it's been taught for many, many generations. And then your last 2 years are the clinical rotations where you start to work with patients, surgery, medicine, OBGYN, and the like. So several things are happening now. I think one is that we're trying to integrate the curriculum a little bit more. It's called systems-based sort of curriculum. So when you talk about it in organ, say the heart, we do everything from the basic physiology and anatomy of the heart to the clinical issues that relate to the heart. So you do everything sort of in concert by the organ or the system. And I think that's probably a better way for the students to learn. It makes more sense. It also gets them a little bit more interested and inspired because they start to see the clinical implications of what they're learning in basic science. And so that's very, very popular. And most of the curriculums in many medical schools have gone to this system-based curriculum to one degree or another. And like everything, is probably somewhere in the middle is probably the right blend. The other thing is I think that we've realized that diversity, breeds innovation. And so I think the class are more diverse. If I was to guess, probably 20 years ago, the class at LSU probably would be maybe 75% male. I'm just guessing, but I'm sure the predominance was male. And this year's graduating class, the predominance was female. Wow. And so over 50% of my students are now female. About 25% of my students are diverse in terms of their heritage. And so we're getting a broader, diverse group of people into medical education, which is the right thing to do. Again, I like to say diversity breeds innovation. In terms of the physician, medicine is so diverse that it really, and there's so many opportunities, that it really affords the individual an opportunity to pursue many different avenues. So if you want to be a researcher, so I've been a researcher throughout my career as well, there's lots of avenues to do that. If you like technology, well then maybe you want to be a radiologist, or you'll be a radiation therapist, oncologist. If you like dealing more with people, maybe you want to be a primary care doctor. If you're more of a listener than somebody who likes to deal with their hands, you might be a psychiatrist more than a surgeon. So it's such a broad field, it's such a rich field, again, that different personalities fit into that. So the idea of everyone sort of being a cookie cutter and everybody being the same, I think is long gone. And I think that's made the practice and physicians better.
Well, what type of student coming out of high school? It's usually those dreams are born in very, very young, or sometimes later on. When you look at the marketplace and the different fields that somebody can go into, medicine still sits at the top, so to speak.
And so if you look in terms of job creation, one of the best professions you can go into is healthcare. The vast majority of new jobs are going to be created within healthcare. Part of that is because people like me, I wouldn't dare to say you, are getting older, and so we're going to be consumers of healthcare. Okay. And so the need will only increase as the baby boomers start to retire and get older. And remember, people are living older now. It's interesting when you talk about medicine and the impact that medicine has on society. If you look at the average lifespan, say in 1900 versus now, 2014, it's increased by over 40 years. But when you look at the impact that new advances in medicine has specifically added to that 40 years, it's only about 7 to 8 years. The vast majority of improvements in longevity are more related to, better living conditions, immunization, people not smoking, people watching their diets and things like that, sanitation. It's not really based just, as most people think, on advances in medicine. It's really looking at the whole healthy community, if you will.
And I think a lot of people will say that too, because they right away, I think realism is that breeds some of the fears of the medical community, because the medical community, at least going to the doctor, it affects people. They have to take a drug, they have to go to surgery, and they're like, hey, what am I getting?
It's a scary experience.
Yeah, it's like, why am I doing this?
So the best way to treat disease is prevent disease.
Exactly.
So I'll tell you something interesting we just did. We were very fortunate and recruited Corey Hebert. I'm sure you know Corey, right? Back to LSU. He was one of our students, but he had left for a while to work with Tulane, another great university. And fortunately enough, I was able to attract him to come back to LSU. So we did an interesting contest just recently, and I was brought along. Okay. And this was to kids in school from first grade to 12th grade. Okay. And the question we asked was, what does being healthy mean to me? And so we gave a group of prizes, and we broke them up in terms of age group. But I just want to read one or two of the things that these students said. So this is somebody from 7th grade. Okay. So have your parents ever bugged you to eat fruits and go play outside? I know it just seems like they're nagging you, but there's actually something serious going behind their, nagging. eating healthy and being active are what keep your body in shape. Everybody should want to do that for their own benefit. Keeping your body in shape will help you now and later in life. So why not start now?
Wow.
Here's one from somebody in the 6th grade.
Okay.
I think obesity in America is the result of an increase in technology and because of advertising.
Wow.
Nearly 70% of children's shows advertising is for foods that have few nutrients. Chips and sugar-filled cereals as displayed in the center of the main aisle of supermarkets with brightly colored packages. Studies show that people are attracted to bright colors. These people should be encouraged to buy healthy foods, okay, instead. In the future, I hope to see that we are encouraging exercise and advertising nutritional foods. Brightly colored packages should be on, not on cereals, but on vitamins.
Okay,
Yeah.
wow.
So, I mean, you know, this is somebody from the 2nd grade.
Okay.
I hope that one day drugs don't exist and people stop smoking. I wish one day people wouldn't pollute a safer environment. I think that everybody should throw trash in trash cans so that the environment can be cleaner and healthier. And big trucks shouldn't put out all that dirty air so I can breathe better.
Wow.
I sometimes think LSU doctors and hope will one day find a cure for cancer and other diseases. But I thought it was incredibly interesting how these kids at a very tender age already thought about the importance of what they were doing as children in terms of their outcomes as adults. And I can say from my own point of view that I certainly wasn't aware of that when I was a child. So somehow the messages of people like you and what you're doing in terms of healthy food, eating healthy, I mean, it's getting out, and that's very important. So I commend you for your good work.
Hey, no, we appreciate it, and we appreciate again that interest, because that's what we're finding, though, that recognizing that you know, knowledge breeds responsibility. Also,
Right.
you know, with too much is given, much is required,
Right.
and for the physician to be at the top and training them, is there any effort placed into training them to understand that yes, they do have a responsibility in the hospital, you know, in the clinic, but also in the community, also to not just push the message, but to be involved in the entire process?
Yeah. So what I tell, as I just told my class when they graduated this past month in May, was that physicians don't treat disease, physicians treat people. We treat mothers, fathers, daughters, sons. And so you have to look at the whole person, and it's not just treating the disease. And I think that was part of the problem of healthcare. So some people would ask, well, how come in the United States we spend more per capita on healthcare, but we have very poor outcomes? I think part of the reason was because healthcare is very fragmented. And so, you know, I see this person for this one specific problem, you might see them for another specific problem, but really who's coordinating the total care? And also, it's the environment and the community that they live in. I can tell you, when I had clinics in Charity Hospital, I can remember once vividly, a woman, her first name was Viola, and she had always come to see me every clinic, would never miss a clinic. She was probably in her 80s. And one day, she missed her clinic, and I was concerned. And so I called her up. The reason she didn't come that day was because somebody had tried to break into her house the night before, and she had to stand by the door to make sure nobody came in because the door wasn't working, so she was afraid she'd be robbed. The point of this is that good health isn't just the physician, it's everything together. It's clean air, clean water, healthy food, access to vegetables, a good education, public safety, it's everything together. Those are the things that make a difference. And I think physicians now understand that we have to look at the bigger picture as well. And it's probably going to be the primary care physician that really is going to be the central coordinator of that care. And that's what makes the most sense. And that's the whole idea of these medical homes that people talk about. It's providing coordinated care for the overall benefit of the patient, rather than this sort of fragmented care. And it's not that the individual care isn't good. I'm sure the care that you would provide and I would provide would be good, but no one's really coordinating the care, so there's lots of redundancy, and sometimes things fall through the cracks. And so you need somebody who's really making every effort to make sure that everything that needs to be done for the benefit of that patient is being addressed, and addressed in a coordinated way.
Well, let's look at Louisiana, though, and because I guess we're right in the middle of it. You know, we fight real hard to make sure we're at the bottom on every area. We challenge ourselves to do that as a state. The conditions for many of the neighborhoods in the city are literally under deplorable, where healthcare is not a concern, but survival becomes a concern.
Right.
You know, yeah, getting shot, and you know, I always love looking at it from the standpoint, I call it New England Journal of Medicine, because they put in so much as far as for the medical community's role in wars and just things that people wouldn't think a doctor shouldn't be concerned about, but because medicine deals with the whole person,
right,
there's this great concern. So I guess again it goes back to
but it's all the other people in that community that need to make it work. It's, you know what I mean? It's the social worker, it's the policeman, it's the teacher, it's everybody. It's really, you know, there was that book, It Takes a Community to Raise, a Village to Raise a Child. Right. It really takes a healthy community to promote good health. It's everybody together. So again, I think that if we're really going to make the continued advances that we need to make in terms of healthcare, right, they're not solely going to be based upon new discoveries in medicine. They're going to be based upon this greater good. And so when you talk about, you know, Louisiana, you know, in terms of being on the bottom, I mean, we have lots of bad habits. You know, one of my colleagues who's an endocrinologist refers to Louisiana and Mississippi as being in the gumbo belt. In other words, you know, we eat a lot of very rich foods, some of which are not necessarily healthy. Right. You know, obesity is very high. We have an epidemic in diabetes and stuff. Mm-hmm. But what you said before rings true. The way to get people to change their behavior is by educating them, making them aware of what's going on. And the best place to start is with the kids, because it starts when you're a child. So if we can have an impact in terms of this early, reach out in the community, right, and help tell these kids why this is so important, and some of them obviously already gotten the message, then I think we've done a great deal, a good service in terms of many years from now. The benefits will show then.
Totally agree. I always, we had mentioned earlier, think back, there was a physician, and his article really stunned me. I think it was in the Wall Street Journal, and he was so upset about the control that was placed upon him by insurance companies, and the control through literally, it was insurance companies more than anything, and he just felt that that physicians shouldn't have to practice this way, and that's what's keeping them from reaching out and helping people.
So I think what eventually is going to happen is the insurance companies are going to get cut out, and that probably at some point the physician is going to deal directly with the patient. You know, there was this bill passed in this past legislature where individuals now are able to contract directly with their primary care physician to provide outpatient services. Remember, the insurance company, I mean, plays certain roles. They're trying to control costs and make sure that certain things are provided. Mm-hmm. So while they're trying to control costs and limit access in certain ways, obviously the physician, you know, feels imposed upon. Right. But in the same way, they're also, in many of them, trying to promote good health and making sure that screenings are being done for, right, you know, colon cancer and diabetes and things like that. So there's a balance there. But there's still somebody in between you and me.
Correct.
Me, the physician, you, the patient. Mm-hmm. And I really think that what the future will be is that we're going to start having more direct relationships, and maybe the insurance companies won't have the same roles that they do now 10, 15 years from now.
Yeah, because they have multiple desires, multiple agendas, and so forth. An insurance company that's operating purely for profit, it's different from the physician who has a care for the patient.
Well, yeah, we have different goals, but remember, the pie is only so big.
Right.
And so the more people that are eating the pie, the less there is. So, you know, one of the things of Obamacare, the Affordable Care Act, was that insurance companies had to pay or use at least 85% of their premiums to make sure they're providing care. The idea was that they shouldn't be making these huge profits and whatnot, right, and so that more care would be provided to the patient. So there are these adjustments that are going on, you know. How you find the right balance, I think nothing occurs overnight.
Well, let's look at this, and just in the idea of the role of the physician in the hospital as opposed to the community. That seems to be shifting too.
So it's hard to be a master of all things, you know, and so medicine is so complex. Mm-hmm. I mean, there's so many medications, so many diagnoses, so many different procedures, that the idea that one person could be the master of all these things and provide the best, most efficient care is not really realistic. Okay. And so what's happened is that, you know, we've sort of compartmentalized this. Mm-hmm. So we have primary care doctors now, which mostly work in the community. Mm-hmm. When they admit that patient, they admit that patient to the hospital, and now taking care of a hospitalist. The hospitalist is somebody who's specifically trained in hospital-based medicine. If that patient now has an adverse outcome or an event in the hospital, they now go to the ICU, where they meet me as the intensivist, right? And so in one way, I understand why it's a concern to the patient, because the patient has developed that relationship with a physician on the outside. There's ways that we can communicate with them in terms of electronic health records and things to make sure that that continuity is preserved. But again, the idea here is that we be more effective, more efficient if we concentrate on the site of where that patient's care is occurring. So again, as an intensivist, I would say I'm better trained than most primary care doctors to take care of critically ill patients. I think most of them would admit that.
Right.
I can tell you without any hesitation that most primary care doctors are far better than me in taking care of those issues that are attended to by a primary care doctor.
Okay.
And again, I think it just speaks to the complexity of medicine. And so while you might think, or the patient might think, they're disconnected from the system, in actual fact, when you look at outcomes and in terms of how the patients do, most of those studies would show that better care is delivered by those people who specialize in that aspect of medicine.
Yeah, and sounds good, but from a patient standpoint, but they actually have more control now because our view of diseases have changed so much. Before, the doctor wrote a prescription, he said, this is what you do, you jump, patient said, how high? Sometimes.
Yeah, well, patients are much more better informed now, you know,
Right.
and want to take control of their bodies in terms of what's going on. But I mean, there's all sorts of patients. There are patients who you know, will never ask you, you know, what to take and whatnot, and there was ones that will come in and tell you what. I remember once a patient came in, had a spot on their lung, and I said, well, I think we're going to get a CAT scan, and he said quite authoritatively, I'd like to have an MRI. And so, you know, it depends on the patient, but I think the good part of this is that the patients are becoming more engaged as an active voice in their care. They're, as you said, they're no longer as passive as they were. And so, and I think that also behooves the physician to make sure that you explain to the patient more what's going on. So sort of what you said before, you write a script and you send them on their way. You know, a big part of medical education is having cultural sensitivities, being able, you know, healthcare literacy, making sure that what you're saying to the patient is something that they really understand. You know, and you have to do it in a way that's unique to them. So, you know, different populations of patients understand things differently. You have to make sure that what you're communicating to them is what you're trying to get across. Because sometimes, you know, there have been studies where a doctor will say something to a patient, and then you ask the patient outside, what did the doctor say? And half the time, it's wrong.
No idea.
And so that puts more responsibility on us to make sure that it is. What we spoke about a few minutes before the show started was also engaging other healthcare providers to be involved in this conversation, like pharmacists. As I was saying earlier, you know, we had a grant where we worked with Xavier pharmacists in their clinics to have the pharmacist as somebody who was also educating the patient about their disease. Why is it important to take your medication every day? Why is it important that you have a low salt diet for your hypertension? Why is it important that you don't eat certain vegetables if you're on Coumadin and blood thinners? And so, you know, I think that patients now deserve and are receiving more information about their condition and how it's best treated.
That's good. Technology. How is technology affecting the practice? I know patients have it because they can dial up their disease and almost pick whatever drugs that they want.
So there's different ways of looking about this. I was once asked so I'm an intensive care doctor by trade, and so I deal with technology. You know, if you've ever been to an ICU, that's where all the technology is. It's nothing but machines and whatnot. And this reporter asked me, what's my favorite piece of medical equipment? I said, the stethoscope, of which she was shocked. She said, why is that, Dr. Nelson? I said, because that's when I actually lay my hand on the patient's chest and feel their heart. And so that's when I connect with the patient. So while we have all this technology, it's also very easy to separate yourself from the patient. And so it's important that you touch the patient, examine the patient, feel the patient. So that aspect of technology is something we have to be aware of, that we don't get disconnected from the patient. Now, the good side of technology is that it provides you with information and data. I can monitor your heart rate on an iPhone. You know, there's lots of things. And so if you think of people in rural areas where there isn't access to physicians, well, those will be great advances. So if there's a pharmacist in, say, rural Louisiana that needs help, or a nurse practitioner, you know, we have telemedicine now, and telemedicine is much more advanced now than it was 10 years ago. I mean, telemedicine is almost the same as if you and I just like this. I mean, it's that good now that you can really make diagnoses remotely. I can listen to your heart, look at your x-rays, listen, look in your ear, examine your skin, all remotely. So the ability of technology now to provide care in areas which are underserved is far greater than it's ever been before.
Amazing, amazing.
So that's the good side of technology.
That's the good side.
But you don't want technology to separate you from the patient.
Okay.
That bond is a very unique bond, because as I tell my graduating students, the patient will tell you things that they will tell no one else. They will expose their vulnerabilities that they will tell no one else. That's a very sacred trust that we have with a patient, and you would never want technology to break that trust, to break that bond.
It separates the physician from, say, a pure research scientist.
Right, so research scientist. So I'm a research scientist. I like to think I'm also a compassionate physician, but they're different skills. They're different skills.
Yeah.
I mean, I look at science as something that hopefully leads to discovery that benefits the patient.
Pure and simple. We only have a minute left. Let's talk about kids, and a lot of kids and so forth watching. What does it take to become a physician? In high school, kids that are coming through in high school that aspire to do that. They have to have a 4.12 and so forth and go for it.
So I always think kids have to be able to dream. If you don't dream, how are you going to do it? You have to have exposure to what these things are. How do you dream? My parents immigrated from Norway, and I'm a first-generation American. Went to public schools, and so I was taught that education is key. That's what you need to do. Mm-hmm. So you have to have good grades. Okay, I mean, and that's just plain and simple. Okay, right. That's sort of qualifying for the race. But if it was just good grades, I could have a computer pick students. Mm-hmm. So it's the total package. It's what are the characteristics of this individual? Are you a caring, compassionate person? Do you volunteer in your community? Are you a tutor for kids in grammar school? Do you volunteer, say, in a clinic? And also, are you from an environment that actually is not necessarily conducive to you going to medical school in terms of your economic situation? We look at the total package. Any child that's interested in medical school, give me a call.
Hey, awesome. Chris Sylvain with Health Issues, Dr. Steve Nelson. As we can see, the role of the physician has changed so much, but what you want to do is ask, connect, ask the right questions, but in everything you do, fight as hard as you can. Thank you so much.
Thank you.